In today's class, we will discuss about how we differentiate LV systolic dysfunction overload from a diastolic overload in ECG. That is LV systolic versus LV diastolic overload in ECG. So, systolic overload will affect the systole part of ECG, while diastolic part will affect the diastole part of ECG. So, in systole, more of the ST segments are affected, while the initial part of the QRS is more affected in diastolic overload. So, here systolic overload occurs because of the LV outflow obstruction. It is actually a pressure overload situation, while diastolic overload is a volume overload situation. So systolic pressure overload, there will be aortic causes are aortic stenosis, systemic hypertension, hypertrophic cardiomyopathy, and coarctation of aorta. So what are the ECG features? So it is a systolic part will be affected. So the QRS height will be, abnormalities of the QRS will be there, abnormalities of the ST segment and T waves will be there, and there will be inversion of the U waves in left precordial leads. Left atrial enlargement can occur secondary to LV systolic overload, and there will be abnormalities of the QRS and the T wave axis. So in the QRS complexes, there will be increased magnitude of QRS deflection. There will be attenuation of the small initial Q wave in the left oriented leads, and increase in the left ventricular activation time. A small equiphasic RS complex in lead AVF and counterclockwise electrical rotation can happen. So in the QRS, what happens is there will be the height of the QRS will increase because of the left ventricular hypertrophy. So usually normally the R wave in V6 will be smaller than that of the R wave in V5. So V5 will be having the tallest R wave. But here R wave in V6 equals or exceeds the R wave in V5. That is because of the left ventricular hypertrophy. So usually V5 is the direction in which the axis is oriented. But because of there is symmetrical hypertrophy, there will be the axis will get slightly deviated towards the V6. So there is an R wave which can equal or exceed the R wave in V5. Regarding the attenuation of small Q waves in the left-sided leads, that occurs because of this systolic overload, there will be hypertrophy. So it will affect the interventricular septum also. So that indicates that is a Q wave disappearing is indicating of the development of the left bundle branch block. So that is because of the increased pressure on the interventricular septum. There will be increase in the left ventricular activation time, that is time measured from the beginning of the QRS to the apex of the R wave. This is also known as the time of onset of intrinsic coil deflection, and it is an indirect measurement of the time taken by the impulse to travel the left ventricle. So that increases, why? Because there is a hypertrophy, so there more muscle mass and more time to travel. So this left ventricular activation time increases more with the systolic overload than diastolic overload, and more changes occur in the ST segment and T waves in systolic overload, because it is a dictum that the T wave forces are directed away from a diseased segment. So what happens is that in LV systolic overload, there will be LV ischemia, and that can result in LV strain. So the left side is affected, so the T wave is directed away from the left, and so the axis of T wave will point towards the right. So there will be T wave inversion in V5, V6, 1 and AVL. That is left directed leads, there will be T wave inversion. So normally T wave in the V6 will be bigger than the T wave, taller than the T wave in V1. While if there is a systolic overload developing, since the T wave axis is directed towards the right side, T V1 taller than T V6 syndrome develops. That is, the T wave in V1 will be taller than the T wave in V6. This is a very early expression of the rightward T wave deviation, and T wave is upright in V6 and V1, but T wave in V1 is taller than V6. So abnormal T wave which we see in this systolic overload will be asymmetrical, and it will have a blunt apex, and the proximal limb is shallower than the distal one. And abnormalities of U wave also develop. There will be inverted U waves in precordial leads, and but this occurs in diastolic dysfunction also, and it is more common in diastolic overload than systolic overload. So LA enlargement occurs, and there will be wide and notched P wave in 1 and prominent delayed terminal deflection of P wave in V1. QRS axis, initially there will be normal axis because there will be symmetrical hypertrophy. So the same as like just as uniformly enlarged. But long-standing hypertension and left ventricular hypertrophy will cause the QRS axis to deviate towards the left side because there will be associated fibrosis of the antero-superior division of the left bundle branch block, and as a result the patient develops left anterior hemi block. So the left anterior part will get blocked and more of the left posterior conduction happens, and that will result in the shifting of the QRS axis towards the left side. So next we will go on to diastolic overload. So in diastolic overload, it's a volume overload. It is because of the overfilling of the left ventricle. So it occurs in like regurgitant lesions like AR, MR, and also if there is a large volume of blood coming to left side as in PDA and VSD. So here what we see is the tall R waves in V5 and V6, and usually V6 is taller than V5. Okay? And the tall wave QRS complexes will be very tall, and it will be even taller than systolic overload condition. So the another thing which we discussed is that it is a diastolic overload condition. So it will more affect the initial part of the QRS. That is the initial small Q and R is affected. So less changes in the ST segments are seen. And here since it is an volume overload, and the T waves QRS complexes will be taller than that seen in a systolic overload condition. What happens is here because of the MR and AR, there will be regurgitant lesion will cause LA enlargement also, and that will push the heart anteriorly, and it will shift the horizontal axis of the horizontal plane of the heart will be shifted more towards the chest wall, and so this V5 V6, and there will be a deviation in the axis towards the V5 V6, and so all the vectors will be pointed towards that. So we will get a very tall QRS, even 40 to 50 mm in AR and MR. That much is not reached in a systolic overload condition because of the displaced heart by the large LA. And in MR, S wave in V1 is attenuated because there is a due to change in the horizontal axis of the heart due to the large atrium. And that is a large atrium because it is displacing it, so that part will get neutralized, and though no S wave will be seen in V1. And the QRS in horizontal axis is aligned to the V6 and makes large impression on V6. So V6 will have tall QRS. And there will be deep narrow Q waves in the left oriented leads. So that is one point which is suggesting a diastolic dysfunction. 2 to 4 mm prominent narrow Q waves are seen because here in diastolic overload, the maximum stress point is at the Q wave point, while in systole it is at the ST segment. So 5 to 10 mm Q waves are seen, and it reflects hypertrophy of the basal part of the interventricular septum, and because of the overload condition. And the Brody effect is a LV cavity with the mass of blood amplifies the Q wave and the R wave. That is known as Brody effect, which is seen in a diastolic overload in ECG. And here the T waves which we see are symmetrical and very sharp and tall, and V5, V6 T waves are taller than normal, and here it will be more symmetrical, sharply pointed arrowhead in configuration. Such tall T waves with tall R waves can see without Q waves. Also sometimes Q waves won't be seen, but we'll see very tall R waves and T waves. That indicates diastolic overload. And only minimal changes in ST segment about 1 mm and slight elevation of the J point can be seen. And inverted U waves are seen here also. It is more in diastolic than systolic overload. And that indicates that there is a compromised left ventricle, and this is more seen in V4 to V6. So these two pictures, the first one is showing a systolic overload where we can see that the intrinsicoid left ventricular activation time is increased, and we are seeing tall QRS complexes and followed by T wave inversion. Because of the left ventricular strain, the T wave is directed away from the left side, so it is moving towards the right side. So here we see the T wave in V1 taller than the V6, and here not much of Q wave changes, and so these are the prominent changes which we are seeing here in a systolic overload. While in diastolic overload, we see the QRS activation, left ventricular activation time is normal, But QRS can reach very tall heights up to 50 millimeter if there is an AR or an MR. And the T waves are same direction as that of the QRS, and they are more symmetrical and pointed and large T waves that indicates diastolic overload. And we will see some Q waves also, and these Q waves are indicating the um, increased volume overload causing septal hypertrophy towards the basal. So we more of vector is pointing away from the leads, and so because of the volume of the ventricular septum is increasing, so there is a Q waves which we see here. So compared to normal, here we are seeing the diastolic overload changes. So this is how we differentiate a systolic overload from a diastolic overload in ECG. Thank you.